in nurses. We're going to talk about a bit of the history and then what is evoked now. Okay. Nursing. We are nurses, so we know what's up in nursing. It has always developed in response to the changing needs of our society. As structures or things alters, as things get evoked, as new things changes, or the old things changes to the new habits in nursing also changes. The custom, the values, our knowledge, everything changes in response to the new thing that is happening now. So this lecture or discussion will explore our contemporary nursing and our nursing roles that have developed in response to the challenges that we are facing in healthcare delivery and what it means to become or be a 21st century nurse. Yes, so I'm sure after this program, it's hope that this class or this lecture will provide us an insight into our nursing program, what we are going to do after here. From our degree level, what are you going to do? This topic will guide us as to the things that are there now, what we are facing now, what we feel we can do in the future. I want to urge everyone that from now, I'm sure after the class ends, I'll get a lot of emails with it, and I'll still put it at the end of my lecture that after here, whatever we discuss, sit down, meditate over it for some time, and then think about what you would want to do as a nurse. Not necessarily I'm done my degree, now I have a degree, so I'm done. No. Very soon, degree will be the very bits in nursing. And so if you have your degree, then what else? So after here, let's all meditate and think about the things we want to do as nurses. We'll get to a point where we'll talk about the scope of nursing, how broad it is, and the things we can do. So as we talk about modern nurses, we nurses we misunderstand our scope of our profession. We think that, oh, just a nurse, I'm done with diploma or at least degree and I'm okay. And then we are just confined. We have to be confined. We have a lot of things we can do as nurses in terms of academics. Even in terms of clinical work, we have a lot of things we can do as nurses. So nursing scope is not just what we see here, but the sky is our limit. It's always said, the sky is our limit. Right, so our learning objectives, we would know the definition of nursing and its application to practice, discuss nursing practice domains, know the scope of nursing practice, explain factors that influence nursing practice, and then the challenges in our practice as well as in our education. For my course, in terms of our nursing practice, always I begin with a quote. Let's read this quote and see if we can say anything about it. We can just give a brief explanation or description about this quote. Can you all see the screen, please? We can all see the screen, right?
Yes.
Yes. So constant attention by a good nurse may be just as important as a major operation by a surgeon. And the one who framed this up is written there. It's one of our nurses philosophers. So what do you think about this quote? What do you think about this quote? Elizabeth Sally, can you talk for us?
Yes, ma'am. What I think about it is that sometimes a patient may not necessarily need a medication to take in, to swallow in, before he or she gets better. But sometimes with the way you talk or you approach the patient alone, how you respond to the patient's needs alone can help the patient recover.
Yes, thank you very much, Lizzie. Yes, so our sister said how you can make the patient, you can approach the patient, how you talk to the patient, how you even eye contact, whatever you do with the patient, not necessarily giving medication to the patient, alone can, in one way or the other, make the patient recover. What else can somebody tell us in relation to this quote?
Ma'am, please.
Yes, please.
Please, I was saying that what I think about this is that sometimes a client may not necessarily need a medication to feel better.
Yes.
Sometimes just a touch of you,
yes.
or giving attention to the client alone. When the client needs you to answer questions, when he needs you by the bedside, whenever he needs your attention and you are readily available, that alone can heal the client before even medications comes in. Sometimes the way you talk to the patient even relieves the patient before any medication comes in. That is what I think about.
Yes, thank you very much. Thank you. Richard Mowley.
Yes, sister. So please, what is written there, my opinion is also just like surgery. We all who have scrapped before see how these surgeons are very careful with the surgery, each way along the surgery, not to cause any complication or to be able to detect the particular problem. So when you come to the nursing side, one of our skills or resources is being observant. Some patients might not necessarily tell you what they are really going through. Let's use pain as an example. You might look at a patient who you might ask, Mommy, the person gives you the feedback, I'm okay. But when you're very attentive and observant, you look at this particular patient and you look at the facial expression or some of the things that you realize that no, this person needs urgent care, this person needs to. So with that, you are very careful and it helps you when you pay attention, it helps you be able to identify the problems of your patient and also help them out.
Very good, Richard. Thank you very much. Grace, you be the last person to talk so that we continue. Yes, Grace Esuman.
Okay, madam, please. I believe your undivided attention as a nurse can help you note other problems a patient is having aside the problem the person came to the hospital with. Sometimes they have sores at areas they are shy to make you aware of, but building trust with them and your inconsistent and undivided attention can make you note extra problems they have and then help them solve it as well. Thank you.
Thank you very much. So we all have all these ideas. Of course, we should have. In terms of giving our attention to our patient, are we on course? Are we doing the right thing? Some, as you all rightly said, not necessarily need medication. Some wouldn't even need a surgery. Sometimes also surgery may be done, but after the surgery, what else? What have we done as nurses? Are we just sitting agile, like sitting somewhere and just hovering around our phones or whatever on the tables, chit-chatting? Most of us do that. From now to the end of nursing practice, we realize that not only the bit about treating the pathology aspect or the disease aspect, but our take is very, very important in relation to healthcare. And so we will know that, okay, then it means that right from the olden days, right from the past till now, nurses have really taken a major part of healthcare in terms of taking care of our patients. And so what are we doing? Are we doing the right thing as nurses? Or we are just sitting agile and then waiting for the surgeons, the physicians, the doctors, even laboratory guys and the radiologists and the sonographers are even of importance than nurses. Is that the right thing you are doing? Well, so at the end of this course, you would realize whatever we are supposed to know in terms of taking care of our patients. Well, we have our we won't start nursing practice without our definition for nursing. Nursing. Definitely, we would have to define what nursing is. So what is nursing in our own terms? What is nursing in our own terms? Any hands raised? Any hands raised? What is nursing? Not necessarily defining it according to our theorists, no, but ourselves, based on our thinking, based on our critical thinking. What do you think we can define nursing in relation to our own words? Yes, Elizabeth.
Yes, sister, I think nursing it's a practice of caring for a patient, someone who needs your care physically, psychologically, and socially, mentally. I mean, as a whole, caring for a patient that is in
Okay.
your care.
That is necessary. Yes. Thank you very much, Lizzie. Thank you. Yes. Who else? Elizabeth Japan.
Okay, sister, please. In my own understanding, I understand the thing to be caring for a person who has acquired the skills and knowledge to care for the sick. Who could have done it for themselves if they had the knowledge and skills a nurse has,
Okay.
but they are not able to do so.
Okay. Okay. Thank you very much, Elizabeth. Thank you. The last person, Alasan Abdul Malik. Yes, you can.
In short, madam, nursing is just a practice of caring for the sick and the infirm.
Okay. Yes. In short, practicing caring for the sick and infirm. That's very
and infirm.
Yes, the sick and infirm. Yes, that's very simple. And yes, you've done well. Thank you. And then one person also said in the chat, nursing is a healthcare profession focused on providing comprehensive care, support, and advocacy for individuals, families, and communities to promote and maintain health, prevent illness, and provide treatment for various conditions. That's from Charlotte Dazi. Thank you very much. Thank you very much. So we all know that nursing is a discipline. And as a discipline, we all realize that the 3 or 4 definitions that we have are similar but not the same. So nursing as a discipline is not defined easily. No, it is not. But if you go to the historians, the theorists, everybody has his or her own way of defining nursing, just that they are all in one go. They are all similar. Instead, it draws its fuller meaning from the women and men who seek to preserve nursing activities in everyday practice. So right from your caring for your patient, the gentle touch, the way the eye contact, the listening ear you provide to the patient, these are all things in relation to nursing. So there is no exact time or place when nursing began. We realize that there's no exact time or place when nursing began. Even in our homes, our mothers always nurse us. You fall sick, and before you realize your mother is doing this, mother is doing that for you. And then sometimes you get better. Even without her taking you to the hospital, you get better, especially with our kids. Yes, so nursing is not really defined, and we don't really know when it started. But gradually, it has become a very big discipline that we as nurses have to pay attention to the nitty-gritties of it and on how we can develop ourselves and know how we can also care for our patients. Okay, so our main mother, right? Florence Nightingale. Florence what? Nightingale, yes. She defined nursing. You know, the definition has been existing for like more than 150 years ago. It's been there for long. And then she defined nursing as the act of utilizing the environment. That we all know. I know we all know because we've done it. Yes. So the act of utilizing the environment of the patient to assist him in his recovery. And it's been stated there, 1860. Mostly when you are talking about references, we always want the current ones. But we have references where you can never do away with the old ones. You can never do away with it. I'm sure you've done, when you are doing project work where we talk about rewriting references with at least 5 years duration, like intervals, as in 5 years old. It shouldn't be more than that. But I have some theories where we have to, even if it is 17 or 15, whatever, we have to, in the 15th century or whatever, we still have to use it. Yes, so Florence Nightingale, we all know that is the founder of our modern nursing and the first nurse theorist. So she raised the status of nursing through education. She defined nursing in that 19th century. She made nursing sort of a discipline for us, and we all know it was just something people were doing at Passan, but then she made it localized in terms of education, where she trained people. We can read more about Florence Nightingale's history when you are done with our course here or our topic here, where she trained people. And so it became sort of formalized. So she considered clean, well-ventilated and quiet environment essential for recovery. So the environment should be clean, should be well-ventilated. Patient has to get a quiet room. Do we see that in our wards? Is it happening? Or is just that if a patient wants just a special ward, that patient can have that kind of serene environment to be nursed? So her definition is reflective of the conditions and practice of her time, particularly during the war. That's what the name of the war, Crimean War, right? During that Crimean War, she defined it at her time. And then the conditions and practices suited that very moment, what was happening. Because that time, because of the war, there were plenty, there were no beds, people were just lying on the floor, being nursed. And so if they are lying there, how better can you nurse them? That is why she specifically stated it in relation to the environment. So her definition emphasized the role of the nurse in creating an environment conducive for healing and health. What do you think we can say about Florence Nightingale's definition? What do you think we can say about Florence Nightingale's definition? You know, those times hospitals and whatever didn't exist. And so when there's accidents, when there's fire burning, when there's whatever, it was just in the homes. You get it? Yeah. So in terms of her definition, so nursing is the art and science of caring for the sick. And nurse is a person who is trained, yes. Yes. So what can we say with regards to Florence Nightingale's definition? And we have to move on. Maybe we can add on Virginia Henderson's one, and then we can see if we can get a differentiations or similarities within that. Well, so our almighty Virginia Henderson's also, she made it, yes. Idris, yes.
Good morning.
Yes, good morning.
What I have to say is more or less into the definition. With the modern day of nursing now, we have moved away from only using environment to using most of chemicals or drugs to heal our with our physician. Thank you.
Thank you very much. I know that is what is happening now. Oh, somebody, Mama nurse, me, Mama nurse, I'm this, Mama nurse, I'm that. Oh, Kotodrewe. Oh, Mama nurse, I'm that, I'm that. Oh, Kotodrewe. Even on the walls, Mama nurse, me have me. Oh, train doctor, ba. But you, the doctor just left. Why didn't you tell the doctor? You as a nurse, what are we doing? And that is the basics of our nursing. That is how we were trained, right from our mother, Florence Nightingale. Our mother, Virginia Henderson, also made it quite modernized in terms of her definition. And I think her definition is quite, we know that often, I think offhand, if you want to define nursing, mainly, even in our nursing, some of our nursing books, is Virginia Henderson's definition for nursing that is quite on the norm. So the unique function of the nurse to assist the individual sick or well in the performance of those activities contributing to health or recovery or to a peaceful death that he would perform unaided if he had the necessary strength, will, or knowledge, and to do this in such a way as to help him gain independence as rapidly as possible. So the first modern nurse to define nursing. And you see, Virginia Henderson's own has a lot to take. It's quite packed, very much. She was a nurse, she was also an educator, and then a theorist, and then she contributed significantly to the development of our nursing theory in this our recent 20th century. So hers is more patient-centric and is aligned with the changing healthcare landscape of our time. Hers is quite modernized. You realize that her definition is quite in terms of what is happening currently to us. Hers emphasized the nurse's role in helping patients achieve independence in the healthcare facilities or activities or the things we do for them. Are we doing that as nurses? I remember I had there was a workshop for us, and then that person for the school, for the faculty members, and then I think that person had an encounter with nurses where it was sort of a mixed feelings. He had one where the nurses were quite not on the good side, and the other one also where the nurse was on the good side in a way. So I think he said his father died, and then before the death, there were a series of happenings. After the death, he said one day his father one day told him that in the hospital that, oh, so apparently through conversation, the man said one nurse bathed him very well, dressed him very well, and because of that, since his admission, that was the day he really slept. So the father died. So when he was coming to pay the bills, one of the bedmates, we have some bedmates or the hospital, the patients who are sort of class prefects in the hospital, in the wards. Yeah, so one of the bedmates called the guy. And then he mentioned his name as if it was his father who was calling him. Then he should come. That's his phone name, Kumu Papa. As the nurse who killed your father. I said, why? He said that I think apparently he got up to go and pee or something. And when he got back, instead of him sitting on the bed, he couldn't really adjusted himself on the bed well. And so he fell, he tripped and fell. And then his forehead hit the floor and he started bleeding. He was sort of on the floor and then no one attended to him. That bedmate said he called the nurse, they didn't mind him. They were all on their phones. And then later, when they realized that the man was having seizures and then they came, rushed him, they were all around him, so the man died. And so he is saying that it's the nurses who killed the man. But if he had tripped and then at that very moment, we had come to take care of the man, it wouldn't have been so. And so he has mixed experience in terms of we nurses. He said that apparently afterwards, they went to after the funeral, they were checking in his father's briefcases and there were a lot of checks. So the checks for the children. So there was one in there, the name was quite unfamiliar. So they were like, our father, does he have any other child somewhere that we don't know? And there was a lot of money in that check there, or on that check there. And so I think apparently he also went to the hospital one day. Then when they were asking around, they had a name called Ajua something. So when they went, they said that when the lady didn't come to hospital or didn't come to work that day, the next day they went there. So after they found the lady, they asked the name coincided with the same name on the check. So then they realized that with a lot of back and forth and then talking, they realized that she was the woman who bathed the man, and then the man had that sleep that he hadn't had it before since his admission to the hospital. That means that without all these medications, all the surgery that have been done and everything, it was the nurse's intervention that made the man had that kind of peaceful sleep that day. And then to the point where the man has even written a check for the lady. It really speaks a lot for us. And so even to our death, are we going to nurse our patient to a peaceful death? Or you feel that, is that what we do? That is a question for the gods, right? Okay. So what are the differences and similarities between Nightingale and Henderson's definition of nursing? Now we know the how do you call it? Florence Nightingale's definition. And then we know of the Virginia Henderson's definition. What are the differences? What are the similarities? Mauli Richard, yes.
Okay, sister. So the differences. One difference is I noted among the two is Nightingale was fixated on the environment. That is a part of the patient's care. But with Virginia, he was concerned about the whole part of the person's healthcare. But Nightingale stipulated just on the environment of the person. But also with the similarities, they were all driving at providing good health for the patient at the end of the day.
Okay, thank you very much, Richard. Yes, they all dwell on the good health of the patient at the end of time. Yes. Symbol.
Yeah, please, madam. What I also get from the difference is that, like what my brother just said, Nightingale focuses more on the environment to help the patient recover. Then the Virginia, I want to also focuses on like the whole being of the individual, like assisting the person, whether the person is sick or well. Then I think the similarities, they all focus on the well-being, like the well-being and the human being recovered. So they all end up by recovering. Yes. So that is what I was saying.
Okay, Symbol, thank you very much. Yes, that's very great. Thank you. Juliana.
Okay, sister. Looking at Florence was looking at assisting the patient to recover. But with Henderson, she was looking at, even if the patient will not recover, at least we should lead the patient to a peaceful death. Okay. Not that we will neglect the patient, but even if the patient will not recover, at least we should assist the patient get a peaceful death.
Okay, I get you. Okay. Get a point as well. Thank you very much. Yes. So as you are all saying, yes. So one with the environment, one with the patient, but all are dwelling on the recovery of the patient. And then, as Julie also said, that one is also about the recovery of the patient. What about if the patient wouldn't recover as well? What are you going to do? Are you going to just leave the patient, or you're going to nurse with it? So Nightingale's definition highlights the nurse's role in creating a healing environment, focusing on the physical surroundings, as we've all said, the surroundings, the environment, and then preventing harm. So like this, my patient that guy told us about, ideally, if it is true, that means that we killed the patient. We didn't prevent harm. So it means that our main mother's take on healing patients didn't really work. The environment, there was something, there was even, the floor was even slippery. So we didn't prevent harm. Then Henderson's definition is more, as I initially, the patient-centered, emphasizing the nurse's assistance in meeting the patient's needs. So there's something I'm doing, now I'm not well, I'm disabled, or I can't really get up, let's say feed myself. So what is the nurse doing to help me in meeting that aid? So that is Henderson. So the patient's needs for health and their recovery. Again, then again, Nightingale's definition is quite broad. It's not quite, it's broader, very broad, and incorporates the idea of nursing as an art. Somebody typed that nursing is an art and science. Yes, very true. So the idea of nursing as an art. She also emphasized the nurse's dedication and the importance of skill in managing the patient's environment. So it's all about the environment, but not necessarily, it's the environment. And so I've just gone to, the cleaner has come clean the place, so we are okay about it. What really are we doing as nurses to manage the patient's environment? Henderson's definition is more concise and practical, focusing on the specific actions the nurses take to assist patients in achieving the health. Again, Nightingale's perspective was rooted, of course, in the 19th century, and then Henderson's own influence, the changing healthcare landscape of the 20th century. I don't know if you are noting them down, including the advancements in medical knowledge. So as the new things are evolving, medical knowledge, new trends, or new technology are coming up, then Henderson's definition comes to play. Even though we still attach Nightingale's definition, but Henderson's own come really to play as much as Nightingale's own. Then both of them contributed significantly to the nursing profession, of course, and then helped shape modern nursing. Their definitions reflect the evolving nature of nursing and the diverse aspects of care that nurses or we nurses provide to our patients. I hope that is clear. In combination, of course, with whatever you've said to us. Let's see the chart if we have something in relation to that. So Nightingale's definition focuses on the environment and its impact on the patient's recovery, yes. While Henderson's definition is more patient-centered, yes, emphasizing the patient's, yes, abilities and then, yes, independence. So like Nightingale, Henderson described nursing in relation to the client and the client's environment. Unlike Nightingale, Henderson saw the nurse as concerned with both healthy and ill individuals, as our sister said. Acknowledge that nurses interact with clients even when recovery may not be feasible, and then mention the teaching and advocacy roles of the nurses. All right, so apart from our theories, the school that Florence Nightingale in a way sort of made up or brought in session, where gradually there has been changes in that school. Now that is what is called the Royal College of Nursing. I think initially there were a whole lot of names. You can go read about a whole lot of names, and then later changed to College of Nursing, and then Royal College of Nursing, found in the UK. And so mostly, if anything in relation to nursing, we take some bit about whatever they say. Also, American Nursing Association is also a very big association in relation to nursing. And so if there are anything also, we take their take. So RCN, that's the Royal College of Nursing, also define nursing as the use of clinical judgment in the provision of care to enable people to improve, maintain or recover health, to cope with health problems, to achieve the best possible quality of life, whatever their disease or disability until this. We've initially said that we don't have one definition for nursing. I can define nursing a different way. You can define nursing a different way, but all boils down to one take. So the ANA, the American Nurses Association, also define nursing as the protection, promotion, and optimization of health and abilities, prevention of illness and injury, alleviation of suffering through the diagnosis and treatment of human response, and advocacy in the care of individuals, families, communities, and population. You see, they have broadened it a bit. Of course, you can't take care of the patient without taking care of the family. You can't take care of the patient without taking care of the community. That is why we have different types of nursing, where we even have the public health nurse, the community health nurses, so that if we are done with our care in the hospital, ideally, we are supposed to hand over our patient to our public health nurses in the community. Are we doing that? No, we are not. Monica. So the central focus in all the definition is the patient. Realizing all our definitions, both even what we defined and then what has been on the slide, is the patient, the person receiving the care. This includes the physical, the emotional, everything about the patient. Nursing concepts and definitions are expanded in both the prevention of illness, the promotion of health, both for the individuals, the families, and then the community. Now, aspects that influence nursing practice in the past. Each person will, anyone who would want to explain a bit about it for us, would just take one and then explain to us. So we have religious values, aspects that influenced nursing in the past, and then even some of them are still influencing us now. some of us, some of the points here, we still have that influence in nursing. Richard Mowley, yes, which one do you want to take and then explain to us?
So I want to take the women's role.
Okay, so afterwards, Elizabeth will talk. Yes, women's role, yes.
Okay, so with that, we always even today we call most mothers nursing mothers when they put to birth. So, and in the past, women were seen as the people who take care of the home, cares of everything. They take care of the family from cooking when the child is sick, and also applies in today modern. Most mothers, especially even on admission, it's hardly you see a dad come around to visit the child or something like that. It's always the mothers who are with the child trying to make sure they are okay in terms of their wellness, their feeding, their schooling, and everything. Just a little I can say about the women's show.
That's very true. That's very true. Thank you very much, Richard. And so we realized that, as he said, it's just recently now that nursing is now 50-50 for men and the women. Even the 50-50 is not so much, but now the men are really taking shape. But still, in relation to our local activities, the indigenous aspect, it's still the women. As he said, you see patients on admission, and then it's always the women. Even if we see a man coming to see his patients or maybe nurse his patient, we're like, hey, no, yeah, deal. We tag the person. Like it's sort of something that is not the norm. Why is it not norm? And so that is why nurses were basically women or females because of that women's role. And then what we are experiencing in Africa is the same everywhere. Just that maybe the other places is quite modernized. So the women are the ones they feel that, oh, you have to take care of this, you have to take care of that in terms of the home. Oh, your son is sick. You are supposed to take care of the son. Oh, the son is on admission. You are supposed to sleep by the woman, by your boy or whatever to nurse him. And I think that's not right. It should be sort of a 50-50 affair. Is that not it? All right. So, Elizabeth. Is that Elizabeth?
Talk about
Yes.
religion.
You want to talk about
The religious values.
Yes, please go ahead.
Religious belief, let's say, assuming a patient like he doesn't want a man, like the Muslims, they don't want a man to attend to them and all those things. So if you're a man and you are a nurse on duty, it restricts you from taking care of that patient too. And then some of them, what do you call it? Blood transfusion or all those things restrict you from giving the maximum care to your patient. This is the little I can say about the religious value.
Yes, very true, Elizabeth. Thank you very much as well. Yes, so as Lizzie rightly said, religious values. So you are a female nurse on duty, and then a man is on duty. There's a male patient. Some males wouldn't want you to attend to them, no matter what you do. Sometimes also they would want you to attend to them, and then they would just feel shy. You know that based on what they are showing, like in terms of whatever they say or their gestures, you realize that they don't want you to come to them. But before you realize you are not there, there's no maleness with you. Sometimes also, even if there's maleness, the patient, the nurse is up to something else, maybe attending to something. So definitely then it means I have to hold on. So that nurse is done with whatever, or you go to change or whatever, change from whatever the guy was doing, and then he will come nurse that man. I remember there was urology, most of the urological conditions affect men more than the females, especially with the BPH, the benign prostate hyperplasia. And so mostly for urological clinics, it is the males are a lot, about 80%, even about 90% are males. And then mostly, I think I was in school when I was doing that, when I was in that clinic. And so I was always coming for afternoon clinic then. And then also the urology was always for afternoons on a Fridays. So what happened was that I was paired with a male nurse, so that when there is this passing of urethral catheter or maybe removal or whatever, penile examination or digital rectal examination, all those things, then the male nurse will rather go and then be the chaperone. So mostly I go there and then virtually I'm not doing anything unless there's a female patient. And the female patients, as I said, there were just a few. So it's true that they wouldn't want you to attend to them. When that happens, what else? But then if you are alone also, it means that you have to try your best and then do it. And it affects the nursing care you give to that patient. It does affect. And then that's about blood transfusions and medications. All those things also affect the care that you give to the patient. This is what the patient needs. But the patient says, because of my religious background, I don't need it. Some patients, you know that, oh, this patient would need a lot of, let's say, maybe 1 or 2 eggs a day. But this is my religion, we don't take eggs. What do you do? So this also affects patients. Yes, Calvin, unmute and talk, Calvin.
Okay, I want to talk about nursing education.
Yes, nursing education.
In the past, there was no like much education like that. From what our matrons have been telling us, say in the past, sometimes they'll be in class 10, 11. And I mean, in the past, they didn't focus much on education. They focused on care. But of late, I think they are nursing school all over. That's like helping to shape the nursing as a profession. Yeah.
Hello?
Yeah, hello.
Yes, please, Calvin, can you go on again, please?
Okay, I'm saying that in the past, per what our matrons and directors have been telling us, they say sometimes they can be in class maybe 11 for the whole like academic year. So there was no smart school then, but now every corner you pass there is a school. There's a nursing school or maybe nursing college that is helping to shape the profession, like the nursing as a profession. So now there is much education on the nursing, which people regard as a profession now. Adam, are you there?
Yeah, I was talking, not knowing I have muted. Sorry. Thank you very much, Kelvin. You know, those times at Garden City, this weekend thing, it was Friday to Sunday, and then you're supposed to be in school the whole day. So the Fridays, the Saturday and the Sundays, mostly now, currently, those are our directors, and then some, no, most of them now are directors. They were then the students in Garden City. And then they would come, they have to be in school on Friday. I think Friday evening. Friday, you start around 3, right? 3 to like 7. And then the whole of the Saturday and the whole of the Sunday. You realize that it was so difficult. So I'm sure some of these things even put some of them off, not even come to school at all. Why would I even, because Monday to Friday, I'll be at work. Then the weekends I have to be at home, nursing my husband and nursing my kids. I have to always come in school. What at all do I want? And so some didn't go to school. But now, as Kelvin said, you find every corner there's education. Every corner there's education. Even apart from the degree, every corner there's education. In terms of even with the masters and the other things. You go to school though, those ones you go to class, but then not so much. So much. So these are the things we are supposed to know and then pick up some bits, that positive aspects out of it, and then encourage ourselves to do more for ourselves. So very, very, very good, Kelvin. Yes, the next one, I think we have the societal attitudes, the war, and then the nursing leaders. Who will help us? Grace. And
yes,
then
madam.
Yes, Grace.
Please, I want to talk about the war.
All right, Grace, when Grace is done, Abigail will talk, and then I think we'll be done. Yes, Grace.
In the past, there were a lot of wars happening inter-countries, even in regions and all that. That was even what led Mother Florence Nightingale into training some people who were volunteering to become nurses, to assist her to care for people. Bringing it down to era right now, there are a lot of nurses currently, and some people even enter nursing with the intention that at least I want to be a nurse in my family, so that if there are any emergencies and minor injuries, I can at least provide first aid to my family before I send them to the hospital. And the education has come down to a extent that mothers are even taught first aid stuff, and then they give those things to their kids or their families before they rush them to the hospital. That's the little I can say. Thank you. Hello, madam.
That is the first. Sorry, I think I've been muting and unmuting myself. I was saying that I've heard you, and then I'm saying that the war is the first that shaped nursing. I think the war ignited the spark in Florence Nightingale. Yes. And then from that aspect till now, we realize that there's a lot of changes, a lot of it. So with the war, even now, currently, even if there's a war, in quotes, in Ghana, I said in quotes, so please, I'm begging you, in Ghana here, our hospitals will be choked. Before you realize, you'll be nursing patients somewhere on the floors, even outside the hospitals. So when there's that, is it endemic or pandemic? When there's that endemic, yes, it's quite localized, yes. That very place, there will be a choke in terms of nursing activities, in terms of even healthcare activities. And that also changes a lot of things we are supposed to do with nursing and with our patient. And that also influences what we have now here currently. You get it? That influence. But without the war, there wasn't any nursing education. There wasn't any discipline called nursing. It was just there. I don't know whether I've also added up to what is it Grace? Grace said. Abigail.
Madam.
Yes.
Madam, so I'm also taking the last one, the social attitudes.
Okay.
Please, with that one, I'll take it in two parts. The first one is the attitude of nurses towards our patients.
Okay.
I believe the way we nurses see our patients in a way influences the kind of care we give. And that is why we are told to see all patients as equal, so that we'll be able to give care without discrimination, and then to give our whole. And then the second one is the attitude of our patients or the society to the healthcare service we give. So with that too, whenever the patients they fully accept the care we give them, we are able, whenever they patronize or they fully accept and believe, we are able to give out our best as well. Thank you.
Thank you very much. Yes, you've explained the societal attitudes and then the personal attitude. This is not something we are supposed to talk about again, because we all know. We all know what is happening, right? We all know. Nursing attitude, we all know. The societal attitude to us also, we all know. Let something about nurses come out. You see what happens. The little bit. It's just recently that there are quite a bit of changes. Even that. So those attitudes also influence nursing practice. What the society is always saying about us influence our practices a lot. It influences in a negative way. It also influences it in a positive way. So what are we taking? Are we taking the positive aspect, or we are taking the negative aspect? And then our attitude as well is also a bit of it. Right, nursing education, certificate and diploma. We have the degree and higher degrees. The education in Ghana here has undergone a lot of changes and reforms, both in the internal aspect and in the external. There are a lot of controversies around our education. So now, there are still controversies with our education. Up to now, yes, the picture you see here is one of our classes in school where our students, these are our own students, our students are writing exams. Yeah, so they say the certificate and the diploma, internal advocates and challenges, while it receives external support. So internally, we are all saying that certificate, we should stop it. We should stop certificate. We should just end that course. Even with the diploma, some are saying we should end it because you realize that a diploma nurse and a degree nurse, I've always been saying they are cheating us a lot. Those of us who are diploma nurses or who started as diploma nurses, they're cheating us. You write the same licensing exams with a colleague, the same questions word to word. You finish and they are 8 years intervals away from you, or you are away from them, or whatever. You can just imagine how cheap that is. And so then let's stop the diploma. So these are all advocates from us all. That the certificate should be stopped, the diploma should be stopped. But for the ministry, no, they like it. So that receives that external support because they feel that with diploma and certificate, how much do we pay them? You get it? We don't pay them a lot. And there are a lot also in the system. So it will help us. But for the degree, at least the salary interval is quite it's quite big or huge. And then right from the degree also, within some few years, you are posted, and before you realize you are the PNO or whatever. And then the salary from the PNO, even the NO and then the PNO, is a lot. I think from the PNO, they are enjoying the full allowances and all those allowances. And so when you get to the PNO, you are good to go. But then NO, the next NO, it's not so much. What about with the staff nurses and the senior staff nurses? You can just imagine how they are cheating us. So that is what they want. They want the external support. They are taking that as their cup of tea. They want it full. But we are not wanting that. And the degree in the higher degrees, of course, internal advocates and challenges, while it suffers external condemnation. So I think with that explanation, you've realized that they also, because of the amount of payments they would pay them, and then how they'll just quickly rise, they'll try to condemn it. But is that the right thing to be done? No. Is that the right thing? No. And so mostly, you realize that those nurses who are now sort of in the higher positions in nursing, most of them started as diploma nurses. They didn't start as degree nurses. It's just a few. For the degree nurses, they feel that, oh, my degree, so I'm done. They just go there within 3 years, they are wearing that blue belt and they think that they are on top of the game. They don't want you to say anything. They will be sitting. Once, I think about a month ago, we went to to do NMC exam for the NACS, the healthcare nursing assistant clinicals. There was one degree nurse sitting down there commanding a lot of nurses. Meanwhile, I think we realized that we asked a lot of questions, and then she just completed about 4 years ago. So before you realize that 4 years now, she's an SNO, so she feels that she has arrived. Meanwhile, there will be a diploma nurse who is now maybe a staff nurse and still hovering around. We should always consider that after this, we will do our degree. After our degree, we will further and further till we have achieved what we want to achieve in nursing. Not necessarily because of our degree, we are done. It wouldn't help us in any way. The reform in nursing education. So it is now mandatory, whether we like it or not. We have to update ourselves. Now, even if you don't update, you see, you be in the hospital, you don't feel fine. You feel fine when you are in the wards, in the hospitals. Somebody who is now who came and then you train that person as a rotational nurse is now in charge. How do you feel? Can somebody share an experience to me? How do you feel? Yes, is it Abigail or Stanley? Abigail.
Mine is a question.
Okay.
The influence of the society on nurse. So I want to ask, is it right for a nurse to work in his own society where he's very known to the roots?
Okay, I get it. Did you hear the question? Is it right for a nurse to nurse in a society where he or she is very known? What answer are we giving him?
Yes.
What answer are we giving him? Yes. Mm-hmm.
Hello, sister.
Yes, Abigail.
Sister, please, I would say I can say it's good and sometimes too it's not good. the better aspects, we can say because they know you and then they trust you, they are able to avail themselves for care. But in the on the other hand, no, for me like this, I'm working in my community where I grew up and all that. And my practical example is one person met me and said, I don't feel well, and I said, oh, that it might be, from the way you are talking, it might be something more than the para you are asking for. So kindly come so that I take you through and then you seek care. And then the next thing I heard from him was that Okrada Ben upon nursing training awareness. Because they knew me from childhood and all that. He started saying, so it's I don't know, it's both sides. It can be good and then it can also be bad.
Thank you very much, Abigail. Thank you. Mavis, do you have the same thing to say or something else?
No, this is about the experience.
The experience. Okay, so let me come in and then you talk about the experience to us. So as Abigail also said about it's dicey, yes. What do you want as a nurse? What do you want as a nurse? Ideally, yes, it's better you are in your society, you grew up there, you know them all. And so with the list and child, I want to go to this hospital because my daughter is here, or this my friend's daughter is here. I knew her from when she was young. She would take care of me well. But in another way, the elders, you know them. In terms of advice that we would give them, you think they'll take, or especially the indigenous, there are some people who are very traditional. No matter what you do, they know that no matter what, you are just below me. I raised you up, or I saw you when you were growing. So it's the other way around, however you want it. But I think the best thing for me is just my opinion. For me, you'd have to, if it's better, you go out there, nurse people or other place, go to your school, then you come there, maybe you'll be hosting some community, a sort of seminar or workshop for them, and then advise them, educate them on other things. That's one, they'll see you quite different. But when you were doing your training, your band 1, you were still there. You vacate from school, you come there, they saw you. Band 2, they saw you. Band 3, they saw you. Rotationers, they saw you. Unless you are up there before maybe you say something, they would try to take. Other than that, well, that's my opinion. Mavis, the experience.
Sister. Okay. My experiences, I started as ward assistant, education to do the health assistance, and some of degree and diploma nurses at my facility. So one day, one of them came back as in charge, and the way this lady was bullying me.
Maybe you have a nice experience you all want to hear. Maybe you have a nice experience you all want to hear. And your network is not so.
She doesn't know me anywhere. Yes, and please, I'm on it. Okay. Why is it that I should be there for those that have trained to come back and bully me like that? Then I continued to further my education as a diploma. Then later I realized that I can't end there. I need to progress. I need to move on. Then I decided to do the degree so that I'll also come out as one of the best trained nurse. That's why I proceed to do a degree in nursing. This is my experience I've experienced so far.
Very nice experience, right? I know one lecturer, she started as a ward maid. I think the same as Mavis, right? Yes. One lecturer.
Please.
Yes, she started as a ward maid, progress, rise up, and then she became a DDNS in CAT. Now she has retired, but then she has done her master's, she has done education. I don't know, I don't know whether she's doing her PhD now or that one, I can't really say, but now she's lecturing. Can you imagine? Can you imagine? And the joy you feel when you get up there and you realize that you were from that scratch. It's so nice, so beautiful. Forgive me, I haven't read most of the charts. In the 18th century, our co-founder was found providing care to wounded soldiers. However, that need has necessitated the introduction of training nurses to a security agency, that is, i.e., 37 military nursing training. That's great. Feel like quitting the job and sit in the house when someone you train coming to be in charge of you and telling you what to do. That's, Charlie, it's not easy. It's not easy. And then most of us diploma nurses have experienced those things. And you know one funny thing? That's good because those things push you. They push you to do something better for yourself. They push you. I'm sure Sister Mavis, if she wasn't pushed, I'm sure she would have ended up with maybe a diploma or the NAC. But she was pushed. So whatever you experience on the wards, forget it. Take cool. Let that push you. You get it, to do whatever you want as much for yourself. Yeah, of course, the KDK will be too much, Charlie. It will be too much. KDKs, you can't handle it. Some of them, when it comes to the Pascal, they are not good, but they'll be flexing on you. The diploma, but the degree nurses, the diploma nurses we train, like as in they train so much. It's recently the degree nurses for us here in Garden City, forget it. We train them. We really train them. And so you go to the hospitals and then most of our nurses from Garden City, they are working well. I'm sure maybe because of most of us, there are diploma nurses and we've risen to that far. And so we are inculcating that diploma habit in them. We really train them. And that's it. All right. So the reform in nursing education, as we said, no matter what, you'll be pushed to go to school. So one of the reforms had to do with the entry requirement for potential nurses. This was to ensure the solid foundation for nursing training, both at the training and the use, of course. Now, if you have that, the 20, okay, now, because of the changes in the grading system, now we have A1, B2, B3. And so someone will get all B3s and then the grade will be quite, you wouldn't get that single grade because of their new gradings. But so now we have cutoffs. We don't just take anyone or any grade at all. Yes. So because of that also, it has brought a bit of changes and a bit of reform in our nursing education. Then the current nursing education reform acknowledges the fact that quite a large number of nurses who acquire dual qualification, that is a certificate in nursing and diploma, are yes. No matter what, you have to go to school. If you don't want to go to school, then it's up to you. The women, don't be saying that, my husband hasn't done degree, so I'm waiting for him to do degree before I go to do degree. Please. Please. Let us do bits about ourselves and stop focusing on the other ones. We have to go to school. The little thing that you can save and go to school. Your husband hasn't done anything. Also on your degree, you do your degree. If he says he won't do his master's, go and do your master. There are lots of things you are supposed to do. Other than that, you just be left on the floor there. In nursing, in your career, then everybody is rising. And you're not rising because at home, your husband says this. These are the things most of our nurses are doing. The men are going, the men are climbing up. You see the diploma nurses, how many now currently have you seen that he was a diploma nurse, let's say 10 years ago, and he's still in the wards? No, even if they are still on the wards, they are there doing a lot of things for themselves. Some are I know a nurse who is at the Kofonochi A&E currently. He's into a lot of things in nursing. World Health Organization, they have a lot of workshops. He travels here and there. He has a lot of connections, but he's still in the ward. So you feel that, where's the award? No. Those men in the wards are doing a lot for themselves. But the women, what are we doing? We are giving birth. That's all. Well, it's up to us. Challenges in nursing education. Dual entry points in basic nursing qualification. Yeah, so that, for especially with the NAC, there's this, you have to do access course, right? Access course before you can get that. Stanley, let me finish with the first point and then you talk, okay? you have to do access course, and then later you enter the degree. With that, sometimes it's quite a challenge because within 6 weeks, you're supposed to learn a whole lot of things. And how can you? It means that you're just chewing and pouring to go to pass, and then come do degree, and then also finish up. These are the people they'll finish up, and sometimes they wouldn't give the best. They'll finish because they want to wear white and wear white belt. But they didn't finish and learn. They didn't go to the school to learn a lot about the rationales, why we do this, why we do that, as a nurse, what I'm supposed to do, how I have to conduct myself, how I have to behave, all those things. They wouldn't go to school to learn that. But they are just in a hurry to come wear the belt. I know a lot of health NACs, yes, the hacks and then the NACs who have completed, and then every day on their status they have the pictures with their white belts. Hey, white belt. What at all is white belt? It's nothing. But that is what they want. So those dual entry points, most of the times the nurses or the nurses who go attain those kind of qualifications are not so much into what they are supposed to know. Please, Mr. Paul, please, are you writing on the screen? Okay, Paul. Yes, Paul, it seems your name is everywhere on the screen. Well, was it Stanley whose hands was up?
Yes, please.
Yes, Stanley, please, what did you want to tell us?
I just talking about the ladies not being able to further for themselves. There are their husbands that once they go further up in their education, like they will come to be a kind of bossy on them in the house. So they sometimes prevent them from doing these top-up programs to better themselves in the field. That is my opinion.
Yes, I get it. That's very true. So, but well, I wouldn't talk much about it. If I talk much, it means that I'm switching from what the main thing we are supposed to do as contemporary nurse, the main thing we are supposed to learn. But ideally, it is men that are insecure. That's saying that they are women who go to school and be bossy on them. If you are really secure, then you know that this is your woman. Why do you have to think that my woman will go and do degree, common degree, and come and flex me? Or my woman will go and do masters and come and flex on me? Then what did you do first to her? This is just, by the way, please. Other than that, I'll switch. All right. So certificate nurses are being produced. But seriously, somebody is writing on the screen. I don't know why I'm also getting that feedback here. I have a blue ink on my screen.
The same as myself.
Yes, so I don't know. Well, certificate nurses are being produced at a geometrically higher rate than graduate nurses. I think we explained that at the reforms of education, right? The reason why certificate nurses are being produced, and that is one of the challenges also in nursing. There's severe shortage of manpower in most of the nursing departments in our universities. Yes, so that one I can speak for us. We are there, we have a lot of students, but the lecturers are there. Faculty members are just a few. Just a few because you all don't want to go to school. Somebody is saying that you go to school and you can't be bossy with your husband. Go to school so that you come and fill up for us. Because we are a few. We are not many. And we are suffering. So go to school. After your degree, I want to see a lot of people going to school and then texting me to tell me that, oh, Charlie, they are here. They are doing their masters. They are doing their this. They are doing their specialties. We'll get there. Severe shortage of, the sabotage by some leaders at the helm of affairs in nursing organizations, the NMCs. You see that our dear mother Perpetual Forian Pofo, she's trying to do a lot for us. But is that all? Sometimes she would want to do a lot, but then some of us, our political leaders and other people will still come and then, okay, no, you wanted this, but let us do it this way. Some will even say that they will sometimes even give you, they dash them money, cars, and other things. That one, I don't know. I've just heard it. And so because of that, a lot of things that they really would want to do for us, they are not doing it. Some of them are also doing well. For her, for instance, we've seen a lot of reforms in her administration. And that's a plus to her and then to all nurses also. What is GEMP? Then only few postgraduate specializations are available in the country, making it difficult for graduate nurses to proceed with academics. And that's true. The postgraduate is not much. You go outside and they have a lot to do in nursing. Even in terms of research, it's not necessarily the person is doing just a master's, but a master's with, into brackets, your specialization. If you are into pain, you are into pain. If you are into burns, you are into burns. If you are into surgical intervention, whatever you want to do in relation to your progress, they would coach you, they'll guide you, and you'll be quite localized. And you are done, and you have that your specialty. But for here, we are limited. You are doing masters in the broad masters. It's just our clinical specialties that we've learned that now they are localizing it in a way. So these are also some of the challenges. And sometimes also because of cheap labor, all these things are there. Why would they want you to go to school and pay you more? We've discussed that. All right. So recommendation. I think that one, some of you would have to tell us. What do you recommend? Nursing education. What do you recommend? Graduate entry medical program. Oh, okay, Beneza, thank you. So that is it about the one, if you want to be a medical doctor, what you'd have to leave, and then after your nursing, you can go enter, I think, is it 3rd year or 2nd year? Is it that? All right,
First
challenge
year.
it. Is it recommendation? You enter 1st year?
Please,
all right.
UDS.
You enter 1st year. And that's a plus. It's a fee, of course, it will be fee paying, but then it's a plus. It's a plus. You can still have to go. You enter 1st year, you go for 6 years. If you have the money, you do.
UCC second year. And you consider your age too.
Oh, okay, your age as well, right?
Okay.
That's good. So some of you from here, you have to join them.
Okay.
Join. You have to join. Yes, that's good. Jackson, are you saying something?
Yes, I think the recommendations you mentioned earlier, my view is that I think our leaders really introduced other CODeL of nursing training to kind of polarize the system. And what is this? That is this incentive to these programs are really the placement after schooling. There are a lot of challenges. Well, I'm into health administration. So sometimes you have these people come from school, and then because someone has made an effort on his own, it's not recognized. And the person, after the knowledge, he's back there impacting and still on the previous grade before he went to school. So there are a lot of policy limitations that are kind of making this decision to advance difficult for some of the young nurses. And I think that, like you mentioned, if your faculty needs some people, I think that would be a way of encouraging people who want to go into academia to sort of not look back into just the ward, but that if you're going to do your master's, you're going to do your PhD, you should be thinking academic instead of coming back to the ward. Our clinical orientation does not really make provision that much for you to be, because how many hospitals, even the teaching hospitals, you want to write a research paper and to get cleared is difficult.
Yes.
So you find that, I mean, some people don't even know this. The information that a nurse can really be an independent researcher who is putting out papers there for people to inform policy. That information is lacking. And that's one of the problems that keeps people just sit back there. You find a lot of village people in the district, very intelligent. They divert in farming and other menial businesses instead of seeking to rise up. I did a program with a London School of Hygiene and Tropical Medicine, and they don't just You don't just do a program. Like they have, you call it need-tailored programs. Like you don't come here, you have people doing just colostomy nursing. In Ghana, it's a strange word. Just recently I met a young nurse in CAT who had gone to South Africa to study. There are many divisions. And I think that maybe the appeal will be to your very good self and those of you in faculty to decide to try and spearhead this, enlightening our young ones to be able to. And I want to touch a bit on the nursing and the husband's thing. I mean, my wife graduated from Ghana 2 years ago. I'm here now because I had to push her to do it. You understand? So really,
that's a plus, right? These are the things I want to hear.
Yes, because I had to push her to do it. And I'm here on her neck again to go back there and do the master's in midwifery because she's a midwife. And I'm ready to sponsor that because it has to really be that we are intentional about it and not feeling secured. So, yes, I think we really have a long way to go. Yeah.
Thank you very much. Thank you very much. Is it your name?
Maunya,
right?
I'm Jackson.
Jackson. Okay. Yes. Jackson, I'm grateful. I'm grateful. You've really touched on a lot of things for me. I'm very, very grateful. And as you said, we faculty have to push whoever is involved. Yes, so that is why we have this thing here we are talking about. After here, I'm sure most of us will have to go read more about other areas in nursing that they can join. We are always ready to receive whoever, especially if you want to join academia. Oh, I want to do this. How would I be guided? We will guide you. I want to do this. How would I, like the path I'm supposed to go? Because as you said, mostly in the clinical field, you wouldn't be told. No one tells us anything. Even when you are going to school, some of the challenges, your matrons, your directors, they'll just be mad, or they will try to sabotage you so much. They try to sabotage you so much, and I'm saying that it's through these sabotages that some of us have left the clinical field, and then we are pushing further. So sometimes these sabotages and these things that they do, it shouldn't necessarily push you to push you down, or push you down, or let you just fall off. No, it should rather encourage you. Thank you very much. Abdul Rahman, please, you are quite disturbing us. So men are talking, boys hide. Oh, not that too. Thanks so much for sharing. Yes, he's done well. So if you're a man here and you have that sort of insecurity based because of that, you didn't want your woman to go to school, especially in her field, not necessarily even in nursing, every field. If you don't rise, you are just a menial person. You can't speak for yourself. You can't speak. Even if you speak, how far will that go? So let's push ourselves. Let's push ourselves. Don't say, I didn't do it, so I wouldn't let her go. Yeah, so we have a lot of things that in nursing we are supposed to do to bring us up there. In academia, we have it. In the clinical field, we have it. We talk about it in a bit. All right, so then the recommendations. Nurses should avoid sentiments and embrace one another. A united single professional team. Some nurses, you have issues with, in relation to a patient. And there some nurses will just go and back the surgeons, the doctors, whoever, leaving their nurses over there to their fate. And most of our directors are like that. Are we also going up there to be like that? We are going to be degree holders. Very soon we go up there. Are we also going to be like that? We'd have that experience, I'm sure, one or the other that we didn't like. Let us be a team. Sacrifice should be made to cancel all other forms of entry into nursing. Yes, of course. Into the nursing program, and then only degree awarding universities at the point of entry. If really we want it, it's not like we want to just degrade anything at all. But if really we want nursing to be that top notch we want, then it has to be started with a degree. Now, teacher training, they are starting with a degree. Now, there's no more diploma. I don't know, yes. Even if there's diploma, I think it is on a reducing value. Now it is the degree they are doing, right from the street. But for nursing, we still do diploma, we still even go do NAC and then hack. Is that the right thing to do? Nurses are encouraged to obtain overseas admission for their postgraduate specializations, scholarship, support, encouragement. You apply for scholarship, you don't get it. Please don't wait for the scholarship. Don't say that, okay. Yes, very true. From some of the leaders, saboteur has been the hallmark. Yes, so we have to stop. Don't say that, oh, I have applied for scholarship or sponsorship or study leave. I have to wait. Me, if I had waited for study leave by now, maybe I'm now doing my degree. I'm telling you, if I have really waited for, you will write for study leave, you won't be giving. Some of our directors and our matrons, unless you put fat money in an envelope, fat envelope for them before they would even agree to even recommend leave for study leave. And we wrote it severally. Some of us, me and my group, we had our degree in 2013, and that time we wrote a recommendation, is it a notification something, because they didn't want us to do our degree. Those times the degree, it was there, but not so much as now. You write it, they wouldn't want to go do it. And so we said we should write notification. We wrote it, they accepted it. We finished. Up till now, I wasn't promoted till I left there. So my promotion was based on the normal ranking. They didn't take my set. As at the time I was leaving there. So you can just imagine. And these are the things that is happening over there. And so then, why do I have to wait for scholarship or study leave or sponsorship? So if I had waited, look at me now, in a way that I am done with my degree. So let's not always hold on to this hospital. My matron has recommended that this, my director, my hospital administrator, please. The little bits we have, we can save it to do something. That is why, apart from the scholarship, they say support, encouragement. If you have a friend, a brother, a sister who is encouraging you, go and do this, go and do this, brother, go and do this. Don't just stand deaf ears to that because, oh, I don't have money. How much do we pay? The school fees, paying it is flexible. Look at Garden City, for instance. You enter, you pay a bit, and then when exams is about to commence, then you finish up. It's quite flexible. And it's the same with the masters, with the other specialties everywhere. It's very, very flexible. So let's do that for ourselves. All right, so career roles are specific employment positions or paths. So as in where you want to channel your nursing career to. Increasing education opportunities for nurses, the growth of nursing as a profession, and a greater concern for job enrichment offers the nursing profession different kinds of career opportunities. So these are a few we have here. Very few we have here. The nurse practitioner, advanced practice nurse, nurse educators, nurse anesthetists, nurse managers and administrators, nurse researchers, clinical nurse specialists, legal nurse consultants, then clinical. Oh, okay, I think these were, it's in twos. I'll just change it before I send it to you. Yeah, so nurse practitioner, who have heard anything about the nurse practitioner? You know, one thing, somebody said research on bullying on the ward. Do you know one funny thing about the hospitals? I think my brother Jackson, right? He said something about when you want to conduct research, and in the hospital, it will give them in a way a negative note. You will send your proposal, and for months they won't accept it. Before you realize, they would even push it somewhere. They won't accept it unless maybe you would send it to, if you are in Kumasi and you want to do something in CAT, and then CAT wouldn't want you to do it. You send it over and over, and they don't want it. You can send it to KNUST. So depending on where you're, if you're in Tamale Teaching Hospital, and there's something in relation to that, they don't want you to do it, you can send it to UDS. Sometimes these are the parts that we don't know. We can just channel our attention. Other than that, if you want to conduct any research, that would be sort of a dent to the hospital in a way, not necessarily a dent. Let's see, bullying in the wards. We do that, and then we correct. You know, research is all about you doing it and then bringing out your recommendations. That will help the problem be solved. And they wouldn't want you to do that because they feel that you are going to dent. So that's a bit about nurse practitioners. They are registered nurses who acquire the expert knowledge base, as in clinical decision making, taking care of patient, clinical competencies for that expanded practice in terms of our patients. This is done also in our hospital in the health sector. I don't know in Ghana if we have nurse practitioners and advanced practice nurses. Please that. Nurse practitioners and then advanced practice nurses in Ghana here. That's the list I have heard though. It's not really here. We call them APNs. Outside it is there. And they are also clinical nurses. So they are there. They can prescribe, they can treat, they can diagnose, they can refer, they can admit, just like the general practitioners. That's why they're nurse practitioners. So just like the general, maybe physicians, they are there. Then we have the nurse educators. That one, we find them here. So we are all part of nurse educators. They are the lecturers, the nursing tutors who teaches in the universities. They are normally registered nurses. All these people or this caliber of nurses we find here are all registered nurses. Anything in relation to nursing, where you find somebody on top of the game, ideally should be a nurse, has undergone training, either 3 years or 4 years, has a certificate as an RJN. And it is there. On all top notch of nursing, we have them. So they are supposed to be also RNs as the nurse educators who have undertaken a teaching qualification recognized by the NMC. That's the nurse educators. We are supposed to be having all that qualification. As a registered nurse, you also have a teaching qualification by NMC. And we are involved also in teaching and preparing nurses for licensing exams. And they usher the nurses into practice. We also teach in the nurse educators teach also in the master's and then the doctoral levels as well, depending on your level or your grade. Are you getting it? You can't be a master's holder and then teach somebody who is doing a doctorate. No, that means they have to be a doctoral person as well. Recently, they are bringing KNUS, they want to do the PhD in nursing there. It is now that they have accepted, even that they haven't started, because they were there. We have doctors in nursing there as well, but then they were few. And then as at last 2 years, there wasn't any professor in nursing there before they were given. Now we have 2 professors in nursing there. And then some are also going forward to be professors. We have senior lecturers there, and then doctors holders or doctoral holders. And so they can start PhD in nursing. So with your qualification before you can do something. Are you getting it? Also, nurse educators, nurse researchers, and leaders in all educational organizations, they are into researching. They undertake research. So whoever is a nurse educator is a researcher. You can't be a nurse educator without being a researcher. So these are parts. From here, I know that some of you, we haven't shared the, how do you call it? We haven't shared the project work, the students to us as project work supervisors yet. Very soon, it will be shared. If it's shared, I'm sure most of you here have grandfathers already. Oh, I have my grandfather. You know grandfather. Grandfather is an old research work from your students, some of your colleagues who have done it, and then they have graduated. They have kept it. Oh, me too, I'm coming to level 400. Give me your old research work. And then you are waiting for her to say, pay. This is your supervisor. And your supervisor will say, oh, bring your concept paper or bring your proposal or bring your work. And you go and dab everything. Me, if you are coming to my end, so whoever, you have to put my name down. If it comes and then you are under me for supervision, please, your grandfather throw it away. You use it. So if you have a grandfather, put it down. Maybe you can just act as a guide for you. Okay, methodology comes, for methodology this comes. Oh, literature review comes, for literature review this comes. Fine. And even at that, we are going to give you that guide. But don't go and doubt somebody's work for us. Because all nurse educators are researchers. And if you are into research and you are passionate about it, your students will come. You want to guide that student to also, in a way, have an idea about research, because we are all encouraging you to go out there to do the best for yourself. And then for the degree level, you go and tell grandfather for me to come back. And then with supervision, we go all out, read word to word to check on your work for you. And you go and bring me somebody's work for me to read it word to word to correct mistakes. You think it's right? It is rather punishment you are giving us. So please, avail yourself. Let us teach you research. And then put that your grandfather away. The nurse anesthetists, they take patients through the entire operative process. And I know that one, most of us, we are aware of that, including the inducing to sleep, monitoring vital signs, adjusting anesthesia levels, and then, of course, waking the patient up after surgery. And then the nurse administrators, right from our mother perpetual Furiampofo to our ward in charges, we are all nurse administrators. The nurse researchers, I have talked a bit about research. And then I think our brother Jackson also talked a bit about research. Some will just avail themselves just for research work. So they are nurses, but just for research, doing research, publishing, doing research, publishing, and then giving out information out there for us to know and then correct our mistakes. Initially, we were doing tapping sponging for adults, but now research is saying that even if you do tapping sponging for adults, it's not working right. For kids, yes, it's still there. They have that effect. Homeostasis, there are changes. But for adults, you didn't get that kind of changes that you want. So every day there is research that is telling us new things. Do we read? That's all about it. And then nurse legal consultants as well. So you just realize a nurse who is now a legal consultant and who is working in favor of patient advocates. What do you think will happen? So our negligence and the things that we do not write on the walls, you have to be careful, because we have them, and then some of them, funny enough, are still clinical nurses with us. They are still with us as clinical nurses. And you do something, they will take you on without you not being aware. They are legal consultants. They are also there. And then I think the clinical specialists, we talk about it. They are also, in a way, a bit about the practitioners, but they have specialties. And that one we know it's all over the place. We have one in oncology, one in hematology, one in pediatrics, neurosurgery, neuroscience. They are all there. Orthopedics. They are all nurse specialties who they are all the training is being done in the Ghana College of Nurses and Midwives in Accra. So they are also there. So whichever you want to do, think about it and choose one for yourself. These ones are just a few. There are lots. But I think in Ghana here, these are the bits that I can say it's really there for us to guide you as to where you want to, the path you want to take. So which one do you want to do for yourself? You do that. Quality, evidence, and safety. So what are we guided by? Nursing professional scope of practice, standards of practice, code of ethics, specialty certifications. Then it comes down to the up to the Nursing Practice Act and rules and regulations. So the professional scope, this is what we are told to do. This is what we've been trained to do. These are the things we are supposed to do. These are our ethics. What is guiding you to be to take that career path? What is guiding you to be that newness, that modernness you want to be? So this scope of practice is part of it. Then it comes up to the Nursing Practice Act and rules and regulations. As we said that it will get to a time where diploma nursing will not be evoked again. It will just start from degree nursing. So if you are there and you don't want to just move up to that high standard, then what else are you now? Institutional policy and procedures. There are some hospitals now, everywhere, they're all going to school. Everywhere it is mandatory for you to go to school. It is a policy or it is something that has been written down that this is what you are supposed to do. Or now it's a degree nurse, you're supposed to do this. You're a diploma nurse, you can't touch this. You're a NAC, you can't touch this. These things will force you to go up there. Then your self-determination. Of course, all these rules will be there. But if you are not willing to do it for yourself, Then what else? What else? Yes. Let's brood over this as well. So our scope of practice. The scope of nursing practice defined as a range of roles, functions, responsibilities, and activities. The things that we do in our setting, the hospital setting. The things that we do in a hospital setting, or the things that we do in healthcare as nurses. In healthcare as nurses, what are we supposed to do? So the scope of nursing is influenced by the nursing, the setting, the requirements of the employer. So the hospital, client's home, community, depend on where you find yourself. And then the employer as well, the hospital. So educational level, professional certificate experience, CPDs, and ethical professional conduct. I think I've explained it with the other slide. Roles and functions of the nurse in all settings. So the needs of the patients, of course, these are some of the things we nurses are supposed to do. The quality of care, best practice, that's evidence-based practice. There'll be a lecture on evidence-based practice, and we understand that better. Then the safety of our patients. We are supposed to provide care to the individuals, the family, and the community. And that one also, we have talked about it a bit. Richard, you are disturbing us. Scope of nursing practice. So this one we talked about the promotion of health and wellness, prevention of illness, restoration of health, and then care for the dying. So this involves these 4 areas. Our scope of practice, ideally, this is our scope of practice. It involves these 4 areas. You get it? So we promote the wellness of the clients who are both sick or healthy, improving our nutritional status, the physical fitness, preventing drug and alcohol misuse, restricting smoking, all these things, restricting alcohol intake, prevention of accidents, all these things are in a way promotion of health and wellness, and then prevention of illnesses as well. Then restoring our health, immunization, our prenatal care, infants care, antenatal care, prevention, education to patients to prevent sexually transmitted diseases. All these things are also part of things you are supposed to do to help patients restore their health, and then care for our dying as well. Are you going to nurse our patients to a peaceful death? Or we are just going to leave them? Always I'll say that, leave them for them to die. Yes. So the nurses are caregivers. Nurses are caregivers. Nurses are patients advocates, collaborators, rehabilitators, counselors, educators, communicators, research consumers, and then change agents. So we all know of our caregiving. That's the bit we all do. Patient advocates. Patient advocates. Who can explain that to us? In brief, patient advocates. Patient advocates. Nurse as a patient advocate, please. Yes. Yes, Xavier. Yes, you can talk.
Yes. Sister, a nurse as the patient advocate. So you defend the patient in all circumstances. You talk for them. You are their mouthpiece.
Yes, yes, that's very true. Very true. Thank you. Collaborator. Who else will talk? Collaborator. Collaborator. Paul. Yes, Paul. Paul. Collaborator. Who will take that for us? Jackson.
Yes. We have a multidisciplinary team that provides care to ensure the recovery of a patient. And so as a nurse, you would ordinarily find that you collaborate with other departments. You are more like the pivot of a patient's care because you attract the doctors that come to do the reviews, ensure the laboratory examinations are carried out as requested, and then you ensure, even sometimes you go to the extent of mediating the bills of a patient, particularly if they are not able to afford. And so all the roles you play around, other than your primary care, to ensure that you attract other service providers to attend to the needs of the patient, makes you a collaborator with the other members of the healthcare team to ensure patient care delivery. Thank you.
Thank you very much. Thank you very much. Rehabilitator. Please, whatever explanation that was ongoing, that's it. However, they've explained, and that's the right thing they've explained. In terms of the patient advocates, Bezra explained it rightly. The mouthpiece of the patient act to protect the client. And then Jackson also explained the collaborator very well for us. Rehabilitator. So mostly it's not necessarily about you've treated your patient and that's all. Afterwards, what else? The bit about rehabilitation is so much that we don't necessarily take it right. We don't take it right. We have to help our patients in complete recovery. As I said, that is why we have our public health nurses. So if there's any way we can't take it on, then let's give our patients in charge of the public health nurses. And they'll be good at rehabilitating our patients for us for complete recovery. Counselor and then educator is almost one way or the other the same. You counsel patients, you educate patients. We always say that we don't advise patients. Research has shown that we don't have to advise our patients, but we have to educate our patients. We have to counsel patients. And we all know we will find some patients in bed, and then before we realize, we go to them, we talk to them, and we find out that they have some concerns that we can address. We can as well counsel patients. If you counsel patient, you feel that it is up to you now, you can't take it anymore, then you can refer the patient to see any clinical psychologist in the hospital. Then communicator, then research consumer. So research is everywhere. So let's try our best and take our research serious. And then agents of change. So from here, we have to be agents of change. Whatever we learn, let us put it into practice, and it will help us a lot. Then factors influencing contemporary nursing practice. Economics. Who take it for us? Economics. Who take it for us? Factors, yes. Why? We said that participating in class is a plus for whoever does that. Please, let us all get involved. We are nurses. We are on the field. We have worked. So all these things we should know. And so it wouldn't necessarily be me talking, but it's in the form of a discussion. And of course, we've achieved that today. Let us just finish up well. You get it? Yes, Jackson.
Okay.
Any of them that you can take and then talk about will be better.
I want to ask, talk about the economics.
All right.
Yes. So really now, I am in private practice. I'm an ophthalmic nurse.
Okay.
And so clinical care is about using the least resources you have to maximize care that you give to patients, because as much as we are seeking to provide care, we are as well trying to remain financially sound as institutions. So wherever you are working, clinical wastages in terms of consumables are really factors that can. So for instance, if you could use just a box of disposable gloves and take care of, there are 100 pieces in one. If you can use that to take care of maybe let's say 50 patients. And now there is another nurse who uses that to take care of just 5 patients. It will not make economic sense.
Yes.
Therefore, as nurses, we're supposed to ensure that we maximize the utilization of the resources to economize in economically sensible way. That your managers, yeah, I mean, they can testify, the whole class. I mean, it's a big class. You can tell that sometimes you do your requisition and they are hesitant in signing.
Yes.
Because the nurse manager notices that you use this, just you requested, say, on Monday, and then the expectation is that it could run a week. There's no any emergency, there's no any outbreak that's rushed in, and then you are standing there again with a requisition.
Yes.
So now, even in pharmacology, we have something we call pharmacoeconomics now, because what is it? We just are trying to ensure that we use minimal resources to maximize care. That for me is my way of explaining economics as a factor influencing contemporary nursing practice. Thank you.
Thank you very much. That's great. Yes, Sylvia.
Sister, I'll talk about the information, telecommunication, and telenursing.
Right.
It has really come to help. An example is you'll be for Western. I'm in the Western region. We don't have none, but I went to the Volta region, Hohoi, and this telecommunication thing has helped a lot. So those in the rural areas, like the cheap compounds, when they get a case that is above them, what they would have to do is to just call the one, the higher facility, and on the phone, they are helping you to treat the case or the case that is above you. If you can't, then you move on. Immediately, the one managing the call will just call an ambulance and move on. So this has really come to, it has really influenced the nursing practice positively.
Okay. That's very good. That's great. Thank you. Thank you, Sylvia. Yes, who else? Mavis. Mavis.
Yes, sister. Mine is about the consumer demands.
Okay.
When you look at the chain of supply, the non-consumables, they don't supply. And when they supply, it's not a period of time. At least, let's say, they give supplies in 2 weeks. And when you request for the gloves, they'll give you less. And once that we are supposed to work for 24 hours, 3 shifts within the week, you see that the consumption to be less, so you won't get to work with. So instead of them to give medication 6 hourly, you see that they will turn it to 8 hourly, so that they can use one gloves to serve at least 2 or 3 medications. So that's my.
So I mean that one is in the negative note, right? The consumer demands is in the negative note. I'm sure we have what in charges here. Please, when you go out there, if tomorrow you may not go to Monday, when you go to please do the right thing. Oh. Let's do the right thing. It's consumer demand, and it depends on the type of condition as well we nurse. The type of condition. We're talking about the glove issue. Depending on the type of condition, you will demand a lot to use a lot. And you don't say that because you have taken this, they will also now try to minimize the things they use on the patient. And it will cost the patient, even cost we the nurses as well. So in charges, please, let's do the right thing. Elizabeth. Our time is far gone.
Yeah,
so before Lizzie, you talk, before Lizzie, you talk, can I come in? You know our time is far gone. Ideally, we have just about 3 minutes left. From next week, let our 7 be our 7.
Okay, ma'am.
So that we can do well and finish up. So if we don't finish up, I won't finish it, and then you'd have to take the slides. Then the rest, maybe you read it on your own and then take your own explanation. Because next week is going to be a different thing altogether. Thank you. Yes, Lizzie, can you talk?
Yes, add a little to the economy.
Okay.
With the financial instability these days within the country and everywhere, I think it has made it difficult for some facilities to procure some items, some consumables and other things. So it makes the care rendering difficult for the caregivers. Sometimes you cannot procure some items like consumables, simple gloves and other things to make you feel at ease to give out your best to the client. And demographically, some of the facilities where they are situated, it is far from the rich. So it makes it difficult for the client to access, and also for even the nurses to even accept to go and work there. So it is making it difficult for contemporary nursing these days.
Thank you very much. So the rest, let's go read about them. We have the rest, there's family structure, we have science and technology, we have legislation, and then we have demography. Better about family structure, what the structure of the family also influences new or modern nursing now, because now it's going to be sort of a nuclear family structure. And so whoever comes in on admission, okay, I come in with maybe my mother, I've come in with my father or whoever. And so it is quite on a limited way, other than we with our extended families where everybody just troop in and then just try to say their own thing. And then sometimes if you get different explanations from a lot of people, it makes the care quite difficult. Science and technology is all about, there are a lot of points in relation to all these things. It's all about research and then the new update that is evoking. Legislation, now because of law and other things, some of us now are doing things right because we are afraid. Now, even there you find some places in the hospital where there are CCTV cameras and other things. If you have found one thing and then we go check and realize that no, that's what you did that you didn't do right. All these things are part of the thing where has now informed us to do things in a new. Then demography, as sister said, in relation to the economics, is also in relation to demography as well, where we would know that these things where we find ourselves also would influence the way I would also nurse my patients or not. Let's be quick in that. I think your next class is 9:15, right? Let me get about 5 minutes of your time to just rush in this. So now influences on future nursing practice, complex healthcare environments, then expanding knowledge and technology. That's the new future. What's up? Changing populations, critical thinking and clinical decision making. We have a topic on that, and then patient safety goals. In a way, that once we have a topic on that. So these are the things that in future, from the way nursing is going on, this is what will happen. Healthcare system now is not going to be just about what we see. There will be new additions. Our knowledge, of course, we are always reading. As we said, now studies is everywhere, education is now everywhere. So you get that bit and then be more knowledgeable. Then changing in our population, of course. So can we get recommended books to look for to help broaden our knowledge on the course? Of course. Send you a book. Critical thinking and clinical judgment and the patient safety goals, we talked about it. Then improving staff communication for best practice. Nursing process. Next week, you talk about nursing process. We know a bit about it, the ADPI. What are we doing with it? Critical thinking and clinical judgment. Then the subjective data, objective data, assessment, and plan. Are we doing those things to care for our patients, to nurse our patients, or we are just taking our folders and then whatever the doctors have written to nurse our patient? No, we have to do our subjective data, our objective data, our assessment, and our planning. The situation background assessment, evidence-based practice, we have a topic on that. And then nursing informatics. You did that in level 300, right? Nursing informatics. Then challenges of contemporary nursing practice in Ghana. No basic working equipment or tools. As we talked about the consumer and then the economics, somebody explained to us, only about 10% of nurses are involved in policy making. In the worst, you wouldn't get even equipment to work on with patients. Nurses have always been called improvisation. Oh, I'll improvise. Oh, I improvise. I remember I was examining one of our students for nursing practice exams. And then there was something that he didn't bring. Oh, madam, please, I'll improvise. Improvise it. Come on, go and take the thing and come and do the right procedure. So I'll improvise. Right from student level, they know the word improvisation because they went to the clinicals and they went to hear about improvisation. That is the quality of education determines quality of care. You think that now that you are gaining more knowledge, when you go out there, no matter what, sometimes it's unconscious, it will come. You nurse the patient in relation to the new ideas that you have gathered. Population increasing rapidly, nature of nursing care changing, increased patient demands to participate in their care, that's patient autonomy. That is also part of our challenges now. So it means that if you as a nurse don't know your rights, as in don't know, are not knowledgeable, yes, that's the word. If you are not knowledgeable, then it means that you yourself, you disgrace yourself. You'll be found really wanting. Increased visibility of provider skills and knowledge gaps, unavailability of essential drugs, poor CPD culture. When there is workshop, let's try our best and join all workshops. It will help us. You know, we don't like going for workshops. I know. Nurses don't like attending workshops, and that's bad. Challenge with acquiring university degrees and specialties. It helps us know more in terms of the CPD culture and then resistance to change. When you go for workshops, it helps you know more. So it shouldn't be that poor CPD, but it should be a better outcome in terms of attending CPDs. Then challenge with acquiring university degrees and specialties. That one, I think we talked about it when we were talking about challenges in nursing education. And then within the profession also, the challenges are, these ones are just English. And then I know we are all facing them. So when you go out there, we just go and then read more about it. The nurses are the greatest challenge to nursing, we know. Less committed to meeting patients' needs, we know. Abdication of routine nursing tasks to others. The things they are supposed to do are not doing, they will give them to whoever, we know. Lack of discipline. So these are all the things we are supposed to do and then counter effect it. Selling of drugs and items to patients whilst on duty, and then training quacks in private hospitals. Now, accountability of a nurse. I think when we started, somebody said that nursing is an art, right? Yeah, so they say it has a heart in, the art has a heart, and the nursing is just a science, but it's a conscience. So let's just go and then brood about these things as well, and then do the right thing from now onwards. Now, these are our recommendations. The nurses should embark on the for innovative ideas that will improve patient satisfaction, reduce cost of patient care, add value to nursing profession, and then shape the future of our profession. That's what we have for today. Let's see if there are things in the chat I have to